Hello. This video lecture addresses bowel obstruction. So a bowel obstruction is a partial or complete blockage of the lumen of the large or small intestine. And some possible causes are adhesions, hernias, tumors or cancer, fecal impaction, volvulus, intussusception, and foreign body. So realistically, we're going to talk about all of those here in further detail shortly. So these are the risk factors of bowel obstruction. So previous abdominal or pelvic surgery is a risk factor because those increase the development of adhesions. Adhesions are essentially scar tissue. There's a slide about that here. In a couple slides. Radiation therapy is a risk factor. History of malignancy, or so malignant cancer. Inflammatory bowel disease. History of previous bowel obstruction, abdominal hernia, and diverticulitis. Those are all risk factors. Okay, so there are two main types of bowel obstructions, mechanical and non-mechanical. So a mechanical bowel obstruction occurs when the bowel is blocked by something outside or inside of the intestine. So possible causes are adhesions, tumors, hernia, fecal impaction, intestinal stricture, that would be like a narrowing of the intestines, diverticulitis, volvulus, or intussusception. So this really would be like a structural abnormality, whether it's something inside of the intestine lumen or outside of the intestines, like pressing on that portion of the intestines, and that structural issue is causing the obstruction. And then there's non-mechanical, and that is caused by diminished peristalsis within the bowel. So here there's not a structural issue that's causing the obstruction. So neurogenic, there are types of non-mechanical: neurogenic, ileus, and ischemic. So neurogenic is basically where there's an interference with the nerve supply in the intestine, and then that causes reduced mobility and peristalsis within the bowel, and the stool doesn't move through the intestines. So the possible causes are listed there: spinal cord surgery, neurological disorders, GI disorders, and then also handling of the intestines during some type of an abdominal surgery. It's important to remember that. So if you have a client who had kind of a major abdominal surgery, they could have a period of time where their intestines essentially aren't moving or working, and it's because of that handling of their intestines due to the neurogenic obstruction. And then an ileus is the temporary absence of the normal contractile movements of the intestines. And then there's ischemic, which is interference with the blood supply to the intestine. So that can actually occur rapidly, and it can lead to bowel ischemia, dysfunction, and infarction, and possible perforation if not treated promptly. So the ischemia is lack of blood supply to the bowel tissue. Dysfunction, it's not working properly. And then infarction means that the bowel tissue actually dies. And then if the bowel tissue dies, then it can perforate, meaning that it gets a hole in it. And so obviously that's an issue. This is a potentially life-threatening condition. Possible causes include arterial embolism, severe hypotension, obstruction of arteries by hernia, adhesion, or tumor. So the type of obstruction and the cause of the obstruction need to be identified pretty promptly so that the patient can be treated properly. So this image depicts adhesions. So adhesions are basically scar tissue that form in the abdominal cavity. The most common cause of those to form would be surgical procedures. So the scar tissue, you can see it attaches itself to organs in the inside of the abdominal wall, and you can see kind of this bigger picture of what's going on. So this scar tissue has essentially wrapped itself around a loop of bowel, and then that causes an obstruction. And you can see why that would potentially cause even some bowel tissue ischemia. And again, this is the most common cause of a bowel obstruction. Okay, so we already talked about adhesions. So then there's intussusception, and that's essentially when the intestines kind of envelope inside themselves. So it's noted really kind of here in a good picture. You can see particularly this area of the intestines. This is kind of going into this other portion of the intestines, and so that's intussusception. And that's a more common issue in infants and young children. And then there's the volvulus, which you can see here. And that's really where the intestines just kind of get all wrapped up around themselves. And you can see why that would definitely increase the risk for ischemia to that bowel tissue. And then strangulation. And this is most common in a hernia. So a hernia, this stuff right here is muscle, abdominal wall muscle, and that muscle got a weakened spot in it, and it eventually made a hole. And then once that hole developed, the intestines kind of went through that hole, and then that causes strangulation, if you will. That part of the bowel gets trapped in there. So obviously stool can't move through there, but really this part, it looks like it's kind of purple. It also can lose blood supply to it, and that can die. So that is a hernia with strangulation. So, preventative measures. Eat foods high in fiber. Limit foods low in fiber. So essentially fiber helps to keep the intestines and stool moving through the intestines properly. It's important for patients to get regular screenings and checkups. Like I think having a colonoscopy at the age of 50 is a fairly common practice. It's recommended to identify, possible cancerous lesions and even other bowel diseases that could further increase the risk of an obstruction. Drink plenty of fluids. Again, increased fluid intakes helps to move the stool through the intestines properly. Exercising regularly is important because inactivity really, or a sedentary lifestyle, increases the risk of constipation. Do not ignore the urge to defecate. That's important. So they shouldn't hold their stool, because if they do, then they might damage some of their structures of their GI tract, and they could kind of lose the ability to voluntarily defecate then as well. So stool softeners and bulk forming laxatives can also be used to try to prevent constipation. So if someone's constipated, that's kind of like one step ahead of having a bowel obstruction. It could, if it doesn't improve, it could ultimately result in a bowel obstruction. So stool softeners can be taken regularly, like daily. The most common one's probably docusate sodium. The trade name is Colace. It promotes incorporation of water into stool, and it results in softer fecal mass, which therefore then helps to move stool through the intestines better. There are really no significant adverse effects related to docusate sodium. Then there's also a bulk forming laxative. The most common one is probably psyllium, trade name Metamucil. It combines with water in the intestines to form a viscous solution that promotes peristalsis and reduces stool transit time. It needs to be taken with a full glass of water, and it typically has no significant adverse effects as well. And that can be taken daily. Just super important to take it with a full glass of water, because if not, if they don't take it with adequate fluids, really they're putting themselves more at risk for constipation. And then stimulant laxatives, those can be used kind of on a temporary, maybe one-time basis for episodes of constipation. And an example is Bisacodyl or Dulcolax. But these should definitely not be used for extended period of time because they can cause the intestines to become dependent upon this medication to stimulate peristalsis. So we don't want our patients to become dependent on this to have a bowel movement. So just important to note, one time only, kind of as needed situation. They should not be taken daily, or they're really going to make their problem a lot worse. So nursing assessment, health history. So history of current illness. So, when did it start? Tell me about your symptoms. What were you doing before it started? What symptoms are you having? GI and other symptoms, including pain. And then also you want to know if they have a history of previous obstruction, because that increases their risk, right? You want to talk to them about their diet and their medications as well as their lifestyle, because there could be risk factors associated there as well. And then their medical and surgical history is important, especially surgical, because if they've had abdominal surgeries, there's another risk factor, right? Their increased risk for adhesion formation. So then your physical assessment is going to include a general appearance assessment. You're definitely going to get their vital signs. You want to assess their abdomen, specifically gastrointestinal, characteristics of stool, and emesis, if there is any emesis, and then their fluid status is important as well, right? They could be dehydrated. Okay, so these are the common clinical manifestations associated with a bowel obstruction. So I'll just let you read through these, but just important to note, they could definitely have some possible fluid and electrolyte imbalances. So it would look like probably a fluid volume deficit if they're not eating and drinking because of this, and then electrolytes would for the most part would be expected to be, it really depends, possibly high if they're dehydrated, but if they're actively vomiting and having diarrhea, they could have some low electrolytes, right? So those, that could go either way. So these are the diagnostics that you were expecting to see. The CMP would be done to assess really their fluid and electrolyte status. The CBC, you're looking for infection. They are an increased risk for infection here, especially if their issue results in a perforation of the bowel. That can cause some other issues that we will talk about here shortly. And they need a BUN and creat. Those would indicate if the client might be dehydrated. If they're dehydrated, those would be expected to be elevated. An abdominal x-ray to see just if they have a bunch of stool backed up in there. And then they might need a CT scan of the abdomen, which would be a more detailed radiologic exam to show the internal structures of the abdomen. And then a barium enema could be ordered to not only assess for possible structural abnormality in the rectal and sigmoid area, but also a barium enema can be used to correct obstructions that are caused by intussusception. So that thick barium kind of, once you insert that, it kind of causes the intussusception to kind of work out the folds, if you will. But important to know that you should not administer a barium enema until the patient has been ruled out for perforation. So obviously, if they have a perforation, you would not want to administer any type of enema. Okay, so potential complications. So We talked about dehydration, so they might not be eating or drinking, so they could be in a fluid volume deficit state. If that occurs, you would expect to administer IV fluids, assess the client, monitor their intake and output is important. Fluid and electrolyte imbalance, we talked about why that can occur. You're expecting here again IV fluid administration, possible electrolyte replacement. You want to monitor their INO, monitor their labs, and frequently assess your client. Bowel ischemia and necrosis, we talked about that really as well. So that's the lack of blood flow to the bowel. And then if that lasts long enough, then their bowel is eventually going to die, which that's called necrosis. And so in that situation, you want to monitor and report client changes and assess for signs of infection and assess their vital signs and, frequently assess your client. So then bowel perforation really could occur as a result of the bowel ischemia and necrosis. And so you'd want to monitor and report client changes there as well, and also assess for signs of infection, assess vital signs, and assess your client frequently. And then peritonitis is an infection of the peritoneal cavity. To address that, you want to monitor and report client changes, assess for signs of infection, assess vital signs, assess your client frequently. So if your client has a hole in their intestines, which would be called the bowel perforation, then all of the contents or some of the contents of their intestines are going to leak into their abdominal cavity, which is the peritoneal cavity. And then that is most likely going to cause an infection there. And that infection is called peritonitis. It's a pretty major infection. Realistically, they're going to need to receive IV antibiotics for that infection, probably for a fairly decent period of time. And then if that's also occurring, if they have bowel ischemia and necrosis, perforation, or peritonitis, they're going to need to have a surgery to, remove that dead bowel and repair it and wash out their abdominal cavity. Okay, so collaboration for these clients. So we've talked about the importance of identifying the type and cause of the obstruction. Mechanical and ischemic obstructions typically require surgical intervention. Neurogenic obstructions that are not caused by ischemia are typically treated with a bowel rest. And then definitely these clients are going to be NPO, so they're not going to have anything to eat or drink. And the diet will be advanced as tolerated per the provider order. And then gastric decompression. So you're going to insert an NG tube, nasogastric tube, to low intermittent suction because you want to, suck all of the contents out of their stomach, or otherwise they're just going to continue to vomit. And I don't think anybody wants that. IV fluids will be expected to help keep them hydrated. They can't have anything by mouth. Manage their symptoms. Frequent GI and stool assessment. They might need parenteral nutrition, and I know we've talked about that in your fundamentals class a year ago, but that would be like the TPN or the PPN where they receive nutrition through an IV, and that's really nutrition that needs to be like a temporary situation because it's very hard on the kidneys, parenteral nutrition. They might need some IV electrolyte replacement because realistically they're not eating anything and they're not really getting the essential electrolytes they need. They also would need some IV antibiotic therapy if ischemia is expected, and especially if they have a perforation. And then obstruction due to a fecal impaction might require manual removal or enema. So fecal impaction, that's where the stool is impacted just in the rectal area, and it would typically be manually removed by a nurse. So some surgical procedures for this issue: an exploratory laparotomy, is a laparoscope that's inserted into small incisions in the abdomen to determine the cause of the obstruction and correct it if possible. And then there can also be a laparoscopic or open colon resection. So that is where a portion of damaged bowel is removed, and then the bowel is reconnected, or if a larger portion of bowel is removed, they might need to create an ostomy. And we've talked about that before in fundamentals. That's where a pouch of the intestines is kind of brought to the surface of the skin and the stool would come out there. And these ostomies can be temporary or permanent depending upon the patient's situation, the location of the bowel that was removed, and how much bowel was removed. So just know that would depend on your patient's situation. And then a surgical embolectomy is a surgical removal of an embolism. So we know, we've talked about, that's a blood clot that is causing bowel ischemia. So if the bowel ischemia is related to, they got a blood clot in one of the arteries supplying blood to a portion of their intestines, then a surgeon could go in and remove that blood clot from that artery to try to restore blood flow. And that's performed only for ischemic obstructions that are caused by an embolism, obviously. Okay, so bowel obstruction. So these are possible complications of surgery. So obviously, having a surgery to repair a bowel obstruction or to remove damaged bowel is a major surgery, and there can be complications from that. So one complication is that neurogenic obstruction that I talked about previously, and that's from the handling of bowel during surgery. And again, that would be typically temporary, and it would resolve on its own after a period of 3 to 7 days, depending upon your client. There can be bowel or other organ damage and or perforation. So, there are lots of organs in the abdomen. So it's possible one of those could be damaged or nicked with a scalpel or other instrument. Peritonitis could occur. I mean, anytime someone has a surgery, that potentially could introduce infection into that area. So if infection was introduced during the surgery, then peritonitis or an infection of the peritoneal cavity could occur. To avoid that, strict sterile technique would need to be followed in the surgical suite. And then there could be a wound infection, and that is an infection of their surgical incision site, and that could result from improper wound care. Patients who have diabetes are at an increased risk for wound infections as well. And then there's wound dehiscence and or evisceration. I know we've talked about that in the past, but dehiscence is where the wound opens up, and evisceration is where like abdominal organs come out of the wound. And so we don't want that to happen, obviously. The most common cause of wound dehiscence and evisceration is an infection of the surgical site. And another thing you need to instruct your clients about after surgery to prevent wound dehiscence and evisceration is you want them to perform coughing and deep breathing exercises, right? So that they can reduce their risk of pneumonia. But while they are doing that, they need to take a pillow and, kind of hold it against their incision site or splint that site so that it doesn't, come apart. Okay, medications. Opioid analgesic, so morphine sulfate. We talked about this in the renal calculi slide, but let's go over it again. So this binds to opiate receptors in the central nervous system. It decreases the severity of pain. It can cause sedation, confusion, hypotension, respiratory depression, and constipation. So frequent vital signs, frequently assessing your client here is really important. And really, if they have a bowel obstruction, they're going to be NPO, so you're going to be giving this IV. So obviously, the fact that it causes constipation is kind of an issue. if they already have a bowel obstruction. But like any medical treatment, anytime you're implementing something or someone has a procedure, you always have to consider the benefits versus the risks. So then also an antiemetic is appropriate, and that would be used to treat their nausea and vomiting. The most common one is ondansetron, or Zofran is the trade name. It blocks the effects of serotonin at selective antagonist receptor sites located in vagal nerve terminals in the chemoreceptor trigger zone in the central nervous system. It decreases the incidence and severity of nausea and vomiting. IV route would be needed here. Again, they're going to be NPO. This can cause diarrhea, constipation, and headache. And then antibiotic therapy is definitely appropriate for ischemic obstructions and or bowel perforation. So, client education. So, if they have signs and symptoms of bowel obstruction, you would need to tell them that they should seek medical treatment again right away. Or also, otherwise, when to seek medical treatment. Really, if they have any questions or concerns, they need to contact their provider. If they would have, you would want to educate them about signs and symptoms of infection, and if they have any of those, to promptly seek medical treatment. They should follow a high fiber diet. They need to exercise regularly once they've, kind of recovered from their major surgery, if they've had one. And then post-surgical education, we talked about signs and symptoms of infection. Also, educate them about their medications and how to take those, and give them information about when to follow up with their surgeon. And also, you're going to educate them about wound care. And these are the websites that I found the information for this presentation. Unfortunately, this content is not included in your textbook, so that's why I included this list of resources for you. So please feel free to click on those and view those. And then otherwise, we have reached the end of this presentation. Thanks for watching.